Thank you. A very good afternoon to you all. I'm Pasan Abeysenevi from the sunny shores of Sri Lanka. And let me first of all thank the GIS for giving me this golden opportunity. I have nothing to disclose. So this is a 61-year-old female with a history of hypertension and breast carcinoma and had undergone a mastectomy in 2013. She was found to be having symptomatic severe aortic stenosis and underwent a surgical aortic valve replacement 2 months back and was on warfarin. Since recent times, she had been complaining of worsening shortness of breath and had admitted with acute angina for 1 day duration. On examination, she was hemodynamically stable, not pale, with well-audible second heart sounds, and in pain. ECG showed ST elevations in AVR and ST depressions in lateral leads. So what could this be? Is this a type 2 myocardial infarction, maybe due to anemia? Or is it a mechanical valve thrombosis or a dysfunction? Or was there a new plaque rupture? Or is this an embolic phenomenon? Or maybe pericarditis? Or is this a rare iatrogenic coronary ostial stenosis? So we were wondering what this could be. And for us to get an answer, we had to go back to the previous angio. So this was the initial angiogram, and there's nothing much that you can see except for minor coronary artery disease. And as expected, the troponins were positive. Hemoglobin was normal. And for the surgeon's happiness, the valve was functioning well. So we had to stop warfarin, and we started subcutaneous enoxaparin and got consent for an angiogram, a check angio. And this is what we saw. So if you look closely, the right coronary artery and the circumflex seems all right, but now you may see that the ostium of the left main is tightly pinched. So what would have happened? Anyway, now this patient was having a myocardial infarction, and she had to undergo an intervention, and she was transferred to our unit. And we had no other option but to puncture the left femoral artery, since following the previous angiogram, she was having a hematoma over the right femoral artery, which was oozing. So this was a 7 French sheath, and a 7 French JL catheter was used. We wired the LAD with a floppy wire, and everything went smoothly. So pre-dilatation was done with a 2x10 semi-compliant followed by a 3x8 non-compliant balloon. And the ostial left main was stented with a 3.5 by 12 millimeter drug-eluting stent. But was this the end? Unfortunately, during the post-dilatation with a 4x8 semi-compliant balloon, the patient suddenly crashed hemodynamically. She was screaming of chest pain, and we did a check. And as you can see, there was a forming clot in mid-left main, which was extending into the ostial LAD as well. So we had to rewire the circumflex as well in this case, and balloon dilatation was done by a 3x8 non-compliant balloon, and then we gave intracoronary glycoprotein 2B3A inhibitors. But that was not enough. Still, the clot was persistent and the flow was not sufficient. So we decided to go ahead and stent from left main to LAD overlap in the previous stent with 3.5 by 18 millimeter drug-eluting stent. And of course, we did an IVUS run, which should have been done in the before the procedure as well. And this showed a well expanded stent. And it was a TIMI-3 flow, patient was stable, and we could successfully send the patient to the CCU. Of course, the plan was to continue IV glycoprotein 2B3A inhibitors, but because of this bleeding from the puncture site, we had to stop it. But we managed to continue enoxaparin. She needed 2 units of blood transfusion. There was a mild AKI, which settled later on. And fortunately for us and the patient, we could send the patient home after starting warfarin. So there are a lot of things to discuss in this case. First, I would like to set my eyes on iatrogenic coronary ostial stenosis, which is rare and may be seen about in 1% following surgical, mainly aortic valve replacement, mainly in the left main coronary artery. This may be acute or chronic. In our case, of course, this was a chronic case because it came after 1 month. But usually acute cases are due to coronary artery spasm, embolization, or due to surgical issues. Chronic presentations might be because of the micro injuries and the local hyperplastic reactions to the infusions given, or else due to the direct damage by the catheters during the catheterization to inject cardioplegic solutions. So maybe retrograde administration of these cardioplegic solutions through the coronary sinus will help reduce this incidence. And the new basket tip cannulae will also minimize the damage to the coronary ostia. And of course, as clinicians, we should always remember these possibilities when such patients present to us. And being interventionalists, PCI, of course, is an effective alternative approach to CABG, especially in these sort of cases where the patients will be hemodynamically unstable and also there might be bleeding, and maybe the patient will not want a reopening as well. And the second mistake we did was not using IVUS initially, but of course later on we did it. So intracoronary imaging is an important thing, and of course patient factors will also determine the presence of these complications, hypercoagulability and resistance to drugs. And maybe we post-dilate the stent too much, so we should always be careful, especially when there are calcified plaques. And aspiration might not be that helpful in these cases because the thrombus is not well formed. So as we did, balloon angioplasty and glycoprotein 2B inhibitors and local thrombolysis will all be helpful. So ultimately, it was a good outcome. So we were vigilant enough and we did situational adaptation well to get a good outcome. Thank you.
Excellent. Let's hear